My name is Roy Morello, and I'm a PhD. And as of July 1st of this year, I'm a professor in the Department of Physiology and Cell Biology and co-appointed in the Department of Orthopedic Surgery and Pediatrics here at the University of Arkansas for Medical Sciences in Little Rock. So I am a musculoskeletal researcher with an active interest in rare diseases, especially those caused by collagen alterations. And our disease of choice for the last 20 years has been osteogenesis imperfecta, also known as brittle bone disease, which is commonly caused by alteration in type 1 collagen, which is the most abundant protein in our body. The severity of osteogenesis imperfecta ranges from mild to lethal, and it dramatically affects the skeleton by causing low bone mass and recurrent fractures after minimal trauma. However, in addition to study the impact of the disease on the skeleton, about 6 or 7 years ago, we began to look to the impact of the disease on the lung and respiration, because osteogenesis imperfecta can cause severe respiratory distress at birth. And also adult patients with osteogenesis imperfecta can often suffer from decreased pulmonary function and are also more vulnerable to diseases such as pneumonia. In addition to that, OI patients were also advocating for more research in this direction. And, OI indeed is a systemic disease that not only impact the skeleton, but also the lung and also other organs. So we were not pulmonologists, so we started a collaboration with a local pulmonologist, with Dr. John Carroll at the Arkansas Children's Hospital. And we decided first to look at histology of lung section of at least 3 different mouse models of osteogenesis imperfecta. And we found significant changes in the lung parenchyma of these mice, which were reminiscent of emphysema, with larger alveolar air spaces and a reduced number of alveoli. And so these morphological differences were accompanied by functional alterations in respiratory mechanics at 3 months of age. Until that point, we had received a small intramural grant from our institution and then an R03 from NICHD to fund this research. But the research was going pretty well. And so we were accumulating more data. So we started looking at additional funding opportunities in this field. And that's where we found, good for us, American Lung Association. So my first application was a little bit rough in 2020 and was not successful, but we were accumulating more data. And so I decided to submit again an application in 2021 for an American Lung Association Innovator Award. And we were awarded it in 2022. And this was a fantastic news that actually reached me when I was on vacation in Italy to visit family. So the overarching goal of the proposed project was to provide a clearer mechanistic understanding of the consequences of congenital type 1 collagen mutation on the lung and respiratory function, utilizing mouse model of osteogenesis imperfecta. And our long-term goal would have been to identify new therapeutic targets and approaches to improve the overall health of patients with osteogenesis imperfecta. And so our studies had 2 aims. One was to determine the consequences of type 1 collagen mutation in the lung, independent from their effect on the skeleton. And I'm going to come back to this in a minute. And then our aim 2 was to identify both cellular and molecular changes in the lung of a different mouse model, CRTAP knockout mouse model, using single-cell RNA sequencing. So aim 1 is basically complete. And it really, this funding from the American Lung Association gave us a wonderful opportunity to develop and validate the first conditional knock-in allele for type 1 collagen. What does that mean? It means that so far, most of the all of our mouse models to study the disease have a global mutation in type 1 collagen, which impacts all tissues. And this does not give you the opportunity to study specifically the impact of mutation in type 1 collagen in the lung, because the lung is contained within our chest, and the disease impacts so severely the skeleton, including rib fracture, vertebral fracture, short stature, kyphoscoliosis, the idea in the field has always been that the skeletal defects eventually have a secondary impact on the respiratory function and the lung. But our previous data suggested that the lung itself and the respiration are primarily impacted by type 1 collagen mutation, maybe independent of the skeleton. And so we developed this new mouse model where we could then induce a nasty, severe OI mutation in type 1 collagen just in the lung, but not in the skeleton. So the skeleton would have been normal, and then the lung instead would carry this mutation that caused osteogenesis imperfecta. And this with the goal to dissect the contribution of the skeletal defects versus those of the primary impact of the mutation in the lung to the disease manifestation. And so we developed this new model and we validated, and the data is now submitted for publication. And then we compare two different mouse models, mice that had expressed this mutation in all tissues and mice expressing this mutation just in the lung. And so in the first model, where basically we reproduced a mouse model with osteogenesis imperfecta, mice also had the classic observed issues in the lung with severe, lung alteration, alveolar simplification. Interestingly, in the second model, which we're finalizing now, we presented some data at the ATS meeting this past May, and we're finalizing the data to prepare for publication. Interestingly, when you express the mutation just in the lung, the phenotype was much less severe. So the morphological differences were almost completely rescued. So we had a normal lung parenchyma. But the respiratory mechanics still suggested that some of the parameters were still altered, indicating that there were still some intrinsic, alterations at the level of the distal alveolar airways. So this data would suggest that the skeletal contributes significantly to the lung impact of the disease. However, we cannot also exclude a potential impact of diaphragmatic alteration in the diaphragm, as well as in the pleural membranes, which are both structures that express a significant amount of type 1 collagen. This is still ongoing. We have now performed the single-cell RNA sequencing on a mouse model of osteogenesis imperfecta and are now zeroing on changes that we see impacting certain fibroblastic population, which are the cells producing the function of type 1 collagen in the lung. And it looks like they also impact the population of alveolar epithelial cells. Basically, we have made a significant progress in this project, thanks to the American Lung Association. But importantly, this funding for the American Lung Association has allowed us to push this project further forward and apply to NIH funding. And I'm happy to say that last year we were awarded a large R01 grant from NHLBI to further pursue these studies in collaboration with a couple of colleagues in the field. So I am very, very grateful to the American Lung Association for entrusting us in the last 2 years to pursue further advances in this field, which is not well known or is well characterized. And in fact, patients with osteogenesis imperfecta oftentimes are not get to be seen by pulmonologists, but hopefully our work will convince the field that this is an important step in the guidelines for the following up of these patients. It's going to be important for them to also see pulmonologists and pulmonology care.